Greetings all, I'm Neil from MeddiQuest. You know, one of the things people have a lot of trouble with the new European medical device regulation is the fact, what is the difference between similar and equivalent devices, particularly when it comes to using them in a clinical evaluation, how they can be used in a clinical evaluation, where they can be used in a clinical evaluation. And we have two new guidance documents from the European Union. Well, they're about a year old now, and they really haven't clarified anything, and that's really because it's all a tragic tale of obtuse legal gobbledygook, pedantic clinical concepts and profoundly unhelpful guidance. Thank you, MDCG. And while we're on the subject of murdering the English language, we've got concepts of similarity and equivalence, and these are actually relatively easy to understand, you would think. So for example, if we look at well, let's go with fried chicken, shall we? Kentucky Fried Chicken, KFC. There's only one. What's equivalent to that? Well, nothing really, except KFC from another KFC store. They're pretty much the same. They're always equivalent, whichever one you go to. More or less, it's much the same chicken out of much the same bucket. There's a definite consistency about it. Similarity, well, that's going down any local fast food shop and going, can I have some chicken and chips? It may be quite close, it may be very different, but basically it's still fried chicken and fried potato. There are a lot of things that are still the same, but you would never mistake it. So things that are similar, things that are equivalent. Bear that in mind when we're talking about the concepts. Equivalence is exactly the same. Similar is the same underlying sort of thing, but not exactly the same, not something you would necessarily mistake. And now we come up with a whole set of multi-letter acronyms. Dew, lurd, Loki, low, sap, sock, sotter, wet. And these all seem to come in here and have a role. And as I go through this, let's hope we can actually make some of them make sense. So we have two pieces of guidance. They both came out in 2020, and their serial number in 2020 are numbers 5 and 6 respectively. 5 is on equivalence. To use my terminology, that's saying Kentucky Fried Chicken is Kentucky Fried Chicken. 6 is on similarity, or you would think it's on similarity. It's actually guidance on sufficient clinical evidence for legacy devices. Or we've got an even more complex title, which is Regulation EU 2017/745, clinical evidence needed for medical devices previously CE marked under directives 93/42/EEC or 90/385/EEC. And that basically, in a paragraph, tells you everything that's wrong with MDCG guidance. It's written by lawyers for lawyers, and no one's ever thought about the audience who's supposed to be reading it. Notified bodies and manufacturers. And I think I'm right in saying that we would all like it just plain and understandable without all these complex legal references and trying to explain and justify the inexplicable and the unjustifiable. Oh well, let's head on. These documents have one really good, clear, well-written paragraph in them. It's on the front of all these documents. It said this document is not a European Commission document, and it cannot be regarded as reflecting the official position of the European Commission. Any views expressed in this document are not legally binding, and only the Court of Justice of the European Union can give binding interpretations on union law. Just bear that in mind when your notified body tells you you have to do something because it's in an MDCG guidance document. Refer them to the front, refer them to the caveat that's written there, and tell them to justify that statement. Don't let them get away with it. They don't understand the law any better than you do. And that's abysmally obvious because of the rapid growth of notified bodies and how a lot of them have very little experience in medical devices. Oh well, here we go. Purpose of clinical data. For equivalence, what we're looking at is that clinical data supports the safety and performance profile, the SAP, of the device under evaluation. And in a similar situation, what we actually have is that clinical data supports the profile of a generic group of devices, well-established technology, or WET. And what we're looking at here are two things really: the state of the art and the standard of care. Are they technologically similar? If you were to do a benchmark exercise, would you say that the state of the art was about the same? And if you look at the standard of care, is that about the same? And we do see some curious notified body positions where they start coming up with things of, well, under the MDR, GSPRs aren't the same as ERs. Therefore, the device under evaluation must be different. The justification must be different. And so the standard of care must be different. No, that doesn't follow. It can be the same. It may be different. It doesn't have to be. When we're looking at establishing equivalence, in the MDCG Guidance 2025, we do have a table in Annex 1 that looks at all the criteria we have to look at. So technically, we need to consider the design, the conditions of use, the specification, both physical, chemical, also probably the scientific philosophy. And what do I mean here? Well, I suppose one way of looking at this is saying if there's software involved, this is probably the algorithm that we're using. Are we using a straight computation? Are we using a numerical method? This level of scientific philosophy that goes into what we're doing and how we're doing it with the device. It's about the deployment, the operation, the critical performance. These we're all looking to get just as good as the Colonel's recipe, pretty much spot on. If we look then at biological components, the materials, the type of contact with the human body, where that contact is, how long it's for, the amount of material that might be released, the amount of substances that might be released, and that's not just things that are normally there with the material. It's about degradation, it's about the level of decay. Things have a shelf life. What may happen over time, what may happen with prolonged contact, what may happen if that's in a difficult environment. Then we look at the clinical side of things. What's the purpose? What a condition or illness are we trying to treat? What's the severity? What's the stage of this illness where we're trying to treat somebody? What's the site on the body? What's the patient population? What are the demographics, age, anatomy, physiology? What are the kind of users? We're thinking not just of perhaps the ethnicity of the users, but we're also thinking perhaps of the socio-economic background of the users. Is there something in common with the users that needs to be considered? Who is likely to use this product? And just like we had for the technical side, we're now looking at the critical performance. What is the minimum that we have to achieve in order for this to be seen as a satisfactory product? Now, similarity, as you would expect from the 06 guidance, has a very much lighter touch definition. And the MDR defines this as a set of devices having the same or similar intended purposes or a commonality of technology, allowing them to be classified in a generic manner, not reflecting specific characteristics. So in my analogy, that's fried chicken and chips. It's not rocket science, it's chicken and chips. So, if we go back to how do we now use, if we've got two devices, we've established they're not equivalent, but they are similar. How can we use this information? How can we use the clinical data from similar devices? And there are various really helpful ways in which this can be incredibly valuable, even under the MDR. So firstly, in the risk management, looking at the risks for similar products, that helps us to understand what we need to look at, what are real risks, what are theoretical risks, what we may have missed out, what we may have forgotten, what we may not have realized was even a risk we can pick up from someone else's experience. Don't reinvent the wheel. Do your benchmarking exercise. Look at other products out there. Look at these similar devices. We can get an understanding of what's going on in the marketplace, the state of the art, the natural course of the disease, alternative treatments. Have we really made the right product? Is this really a product that we want to put on the market? We can also use this to help define the scope of the clinical evaluation. What have other people done? What level of clinical data have they looked at? Shouldn't we be doing the same sort of thing? And we can use this for input into designing our clinical investigation plan. What do we really need to get from a clinical experiment? What can we get from our post-market clinical follow-up? What can we get from post-market surveillance system? Where are we going to generate our information? One of the things we do, and I really am against, is this idea of saying, oh, the MDR, this means we've got to have a clinical investigation of our exact device. That means we've got to start experimenting on human beings. And gee, if we're doing that, well, let's shortcut it. Let's just jump straight to that because we're going to have to do it in the end anyway. No, still have to try and do everything else first. And our similar devices can also help us with working out what our clinical outcome parameters need to be. What do we want to get out of a clinical investigation? What do we need to get out to show something different, something that hasn't been shown before? What are we trying to do differently with our product? And lastly, they can help define what are the minimum requirements for a quantified clinical benefit. All devices have a different risk associated with them. How are we going to weigh this risk against the clinical benefit? What is the risk of our device? How does that compare with similar devices? What are the benefits of our device? How does that compare with similar devices? And does that give us some way of measuring whether we've got a better or worse benefit risk assessment in all cases? For specific populations, how should we look at that? A lot of really valuable information comes from similar devices. Mustn't lose that just because they're not equivalent. Doesn't mean that we can't use any of the clinical data. Clinical data is clinical data. Doesn't matter where it comes from. It can still be. So I guess diagrammatically, what I'd like to do in conclusion is just look at how this all fits together. If you think what we've got is a field of similar devices, some of those head over towards the right-hand side. They're a little bit more sophisticated than our device. And there's a threshold of clinical evidence that's needed for some of the less sophisticated devices, for some of the more sophisticated devices. And of course, with the less sophisticated devices, they tend to have been around for longer. If they haven't gone out of fashion, there's probably a fair chunk more clinical evidence available for them. So this is sort of our threshold we've got, or we had under the MDD, under the old directive. And under the new regulation, well, it's basically a bit higher, but it's not dramatically higher. It's still basically much the same level, and in some cases you can even argue that it might be seen as a little bit lower. And then if we look at our device that we're looking at, if we look at our target device and then we look at a legacy device, if we have the same product under the medical device directive and we've simply kept it basically the same and just done a few tweaks to it, it's probably a very close neighbour. It might even be overlapping in areas. It might be very, very equivalent. It just happens that we've looked at the clinical assessment slightly differently under the requirements for the MDD rather than the MDR. And this says that bit that's missing, that difference between what we require for the clinical evaluation under the MDR and the new MDCG guidances, as opposed to the MDD and the old MedDev guidances, may be something that we can get from surveillance data on the old devices. It may be something we can get from similar product data. It may be something that is actually there already. It's not necessarily driving us to a new clinical investigation. We may already have the data that we need. So, few closing thoughts. Similar and equivalent are very different things. Actually, particularly today of all days, the day I'm recording this, the European Union has come up with the wonderful bit of greenwash which says nuclear and gas energy are now classed as green. No, they're similar. They're types of energy. You can't say it's green energy in the same way as wind power or wave power. Come on. This is similar. This isn't equivalent. This is classic Eurospeak greenwash. You know, I wish the people on the environmental side of the European Commission would read some of their own medical device guidance documents on occasions. Oh well, there we go. We need to use all available information before we start jumping to the conclusion that something is missing. We need to really understand the whole data field, where the clinical data is, how it's been generated, the sort of use, the sort of device, the sort of patient population, where that comes from. And we may find that we've actually got everything we need out there. We just have to use it in the right way. We tend to talk glibly about clinical trials and clinical investigations. And what's really happening here is we're experimenting on human beings. And this is a concentration camp mentality. This is saying, I don't believe it unless you can prove somebody. And you whack them over the head and they say, oh, that hurt, didn't it? No. Human experimentation is generally unethical if there's any reasonable alternative. And if you find your notified body or anybody else starts telling you otherwise, you start throwing the Helsinki declarations back at them. Make sure they can do the ethical justification for you if you disagree with it. This stuff is difficult. And don't assume your notified body reviewer knows the requirements any better than you do. One of the reasons why we have this big statement on the front of MDCG documents is because they're not sure either. They're trying to say something that's consistent, but in individual circumstances you have to apply a degree of pragmatism. And you know, the gap between what you have and what you may need may not be as large as all the paper that's been written trying to tell you what that gap is. It may not be as big as perhaps you thought it was. So my closing thought on all of this is, before you jump into saying we haven't got an equivalent device, we have to do a clinical investigation, think of the data that you're actually missing. Try and look at all other ways you can get that data. And what you're left with may be very small. Thanks for your time. I'm Neil. I'll be back with you again soon.